This is Sally Schessler, Director of Education for Allergy and Asthma Network. Welcome to Advances in Allergy and Asthma, a webinar series that helps Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. It is presented in partnership with the American College of Allergy, Asthma, and Immunology. Today, we are joined by Dr. Brian Robertson, who's going to share valuable information with us about sleep and sleep issues. Dr. Robertson completed his undergraduate training at the University of Georgia and his medical doctorate from the Uniformed Services University of the Health Sciences, or USUHS. He is board certified in pediatrics, allergy and immunology, and sleep medicine. Dr. Robertson has 25 years of U.S. Army experience and has had multiple hospital leadership roles at the clinical service and departmental levels. He served as the Chief of Allergy and Immunology at Walter Reed National Military Medical Center and the Allergy Immunology Consultant to the Surgeon General until his retirement from the Army in January of 2021. Dr. Robertson is an Associate Professor of Pediatrics and Medicine at the USUHS. Dr. Robertson is currently the Chief Medical Officer for Nightwear Incorporated. Dr. Robertson is a co-chair for the American Academy of Sleep Medicine's Interscore Reliability Program, which standardizes the way pediatric sleep studies are scored nationwide. He is a fellow of the American College of Allergy and Asthma and Immunology and the American Academy of Pediatrics, and volunteers on ACAAI committees and as a House of Delegate member for the college. Dr. Robertson, thank you so much for being here. We're looking forward to hearing what you have to share.
Thank you, Sally. I appreciate the introduction. Thank you all for attending. I'm going to talk about something that's near and dear to my heart, which is sleep medicine and how allergies affect sleep. So I actually got into sleep medicine because when I was a practicing allergist, I had patients that had allergic diseases and they had real trouble with sleep fragmentation, daytime sleepiness, and problems like that. So we're going to talk about one specific. So before I get started, I'm just going to say I have to do my disclosure. So as Sally mentioned, I am the Chief Medical Officer for Nightwear Incorporated. We have a device that treats nightmare conditions. That's the only device that we have. It's a very tiny company. We're not going to talk about nightmares in general here, except for one little part when I talk about Montelukast cast. But definitely not anything that this company would be involved in. And then I do some consulting work for Novartis on urticaria. Okay, so our objectives. We're going to talk about how sleep problems are a result of allergic conditions. I'm just going to go ahead and say it right now. We're going to really focus on the nose problems as they relate to sleep. But I will let you know that there are plenty of allergic conditions that contribute to sleep fragmentation, poor sleep, and daytime sleepiness. But we're going to just focus on the nose problems right now. We're going to talk about nasal anatomy and physiology as it relates to sleep, and then we will talk about how to effectively treat nasal congestion in the setting of CPAP use, which is a big topic. CPAP use is a pretty common thing to run into. I like to start this off with a pediatric patient of mine that I had. This little boy was 11 years old, and he had what we call an adenoidal facies. And if you don't know what that is, if you look on the screen here, you can see a child with a very typical adenoidal facies. So this little boy came in, he complained of snoring and restless sleep, and he had excessive daytime sleepiness. He actually showed up in my sleep clinic. When you look in his mouth, he had two findings. One were that his tonsils were pretty big. They were 3+ in size. And he had a high arch palate. So for those of you who don't know what a high arch palate looks like, these are a couple pictures of the high arch palate. You can see that there are with your teeth, you have the gums here, and then the start of the palate, but then there's a step off. Some people call it like the cathedral ceiling. That's the bottom, that's the floor of the nose, and it's also the roof of the mouth, the hard palate. In more severe cases, you can get this sort of triangular shape to the maxillary arch, which you see in this child here, and it can get even more severe than this. So this little boy had these complaints. He was kind of notable, and it sticks in my mind because after our appointment was about 11:30, and they were going to go, him and his dad were going to go eat lunch. And his dad mentioned he was going to gulp down some food, and I asked him what he meant. And it turns out this boy couldn't breathe through his nose at all. And it was such a problem that he would take a deep breath through his mouth, put food in his mouth, chew it up in a hurry, and swallow so he could breathe again. So this is kind of how he like ate every meal, which sounds terrible, right? So anyway, we looked at him. We said, well, yes, you probably do have some kind of sleep problem. He got diagnosed with sleep apnea. AHI stands for apnea hypopnea index. It's just the number of breathing events per hour. So he had 8.2 events per hour. And that would be classified as moderate sleep apnea for a child. So he was sent for two things, one rapid maxillary expansion and the other for tonsillectomy and adenoidectomy. And I actually put an allergy consult into my colleagues and for rhinitis evaluation. So for those of you not familiar with rapid maxillary expansion, this is a device that goes on the teeth of the maxillary arch. And it has a mechanism in the middle, and the parents have this little Allen wrench. And every day after it's installed, they kind of spread it just a tiny bit, less than a millimeter a day. And that's spreading, and then over a period of time, it's usually around 6 or 8 weeks, then it's left in place for a few months, and you expand this palate. And it does a couple things. It changes the shape of the maxillary arch. It actually creates more space in the nose, so the nasal volume will go up with this procedure. And it kind of flattens things out. And so you can see this is a palate deformity before and after this rapid maxillary expansion. A similar procedure, by the way, for people that treat a lot of adults, if you run into this, it can be done. I believe my orthodontic friends tell me that this is a little bit more involved when it's an adult, but for children, this is a really easy, fairly easy thing to do. So after the sleep study, he came back, he came back for a repeat sleep study after the tonsillectomy and adenoidectomy, and he came back and had a rapid maxillary expansion done, and his AHI was 1.6. So AHI of 1 or more is considered sleep apnea in children, and so he was really close to normal at this point. I should also point out tonsillectomy and adenoidectomy is the first-line treatment for sleep apnea in children in almost all cases. He did have allergic rhinitis, and we started immunotherapy on him. So when I think about, everyone's here is familiar with the atopic march, I hope. The atopic march is, asthma, food allergies, atopic dermatitis, and asthma. But this is something we call the core diseases in sleep medicine. And they're kind of similar, right? And the reason that we group these together is because, like the atopic march, these diseases tend to go together, and they tend to influence each other. So the cough, the C stands for the cough or asthma, obstructive sleep apnea, rhinitis, and then esophageal reflux. And so an example of some of these effects, if you have obstructive sleep apnea, you have more negative intrathoracic pressure, and that means that you have more negative intraesophageal pressure. And so there's kind of the sucking up of the stomach contents into the esophagus when you have obstructive sleep apnea. So fixing obstructive sleep apnea can often improve esophageal reflux quite a bit. Esophageal reflux will cause inflammation in the upper airway, including in the nasopharynx, which can contribute to rhinitis. And then aspiration of stomach contents can worsen asthma, as we all know, or even microaspiration that we know happens a lot with esophageal reflux. And so that's just a few examples of the way these things work together. Rhinitis can make obstructive sleep apnea worse also, and that's actually the focus of what we're going to talk about today. So when these are the ARIA, this is a little picture of the ARIA guidelines, and the ARIA guidelines, divides up rhinitis into intermittent and persistent symptoms, and then mild and moderate severe symptoms. So the moderate and severe symptoms, I'll just draw your attention to that. The first thing on the list there is sleep disturbance. So it is not an unrecognized problem that allergic rhinitis leads to sleep disturbance in patients. In fact, a lot of times that's how they present, especially if it's an indoor allergen like dust mites or cat or dog that's causing the patient's problems. 68% in one survey of adult patients with perennial allergic rhinitis reported sleep disturbances. And then there was a large survey done about 20 years ago or so, the Pediatric Allergy and Asthma Survey. And in that survey, the parents, about 40% of the parents reported that allergies affected the children's sleep, with congestion being really the most bothersome symptom. There is an association between sleep apnea and allergic rhinitis that's been deduced. This is a study from, I believe it was 2004, and is a case control trial. And what they did was they looked at a bunch of patients in a sleep clinic that had sleep apnea and compared it with controls. And the controls were COPD patients that were age and sex matched. What they found was that there was an increased incidence of perennial allergic rhinitis in the sleep apnea patients compared to the ones with COPD. You see the numbers here, 23%. So that's, have dust mite allergy. That's a lot. We're talking almost 1 in 4 of these sleep apnea patients have this perennial allergic rhinitis, which is pretty impressive. I'll also tell you, this feels correct when I think about my patients that I see in sleep clinic. I have never treated so much untreated nasal congestion in my life. And until when I got to sleep clinic, I was doing it all the time. In allergy, you treat a lot of other problems like urticaria and things like that. Much more of it. It felt like a lot more when I was in the sleep clinic. I'm gonna get my slides to advance. There we go. So this is the sleep apnea cycle, and patients will go through this period. So when you it's not wake apnea. So when you are awake, your muscle tone and your airway is pretty tight, and the nasopharynx to oropharynx down to your vocal cords, that space is held open not by cartilage or bone, but by muscle tone. So it's like a tube of muscle that you breathe through. When you fall asleep, though, those muscles start relaxing, and if they relax too much, or if the airway is narrow for whatever reason to begin with, then the airway can become so narrow that it impedes the flow of air through the upper airway. And sometimes it'll collapse. We call that apnea. If it just collapses a little bit, we call that hypopnea, or just decreased breathing. The airway collapse happens, airflow stops, and so then the patient won't start breathing again until they wake up, which is what happens. They have those little micro arousals, and they restore their airway tone, and then they go through it again. So you can see this is like a cycle. And when you look at a sleep study, what you see are these, we call them trains of apnea events that can go on for several minutes in patients. In really severe cases, like it just goes on all night long. But patients will often do this. They'll have cycles of it where they'll have many events in a row. Because one of the things that happens is one of the more vulnerable times for your airway is when you're transitioning from wake to sleep. And so every time you transition from wake to sleep, those muscles relax too much, they collapse, and then you wake up again because of the apnea. It makes for really bad sleep. PAP, or positive airway pressure, and we often use the acronym CPAP, so continuous positive airway pressure, but there's other forms too. It's pressurized air to keep the airway open. So this was developed in the late 80s, early 90s, and they actually used a vacuum cleaner motor to be the first developed this to blow air into the patient's airway and use air pressure to keep the upper airway open. And that's what we're doing. We're making more space with air pressure here. There are problems using this, a lot of non-adherence issues. So increased nasal resistance, which we're going to talk about a lot. Skin discomfort and skin irritation. I have seen 1 or 2 patients that have had contact dermatitis from the equipment, that the mask and the straps that they're wearing on their face. And then claustrophobia can be a big issue, although with newer masks that don't fit over the nose, that's much less of an issue because the mask really isn't the patient's eye line. And then there's noise issues and travel issues. And with newer machines, the noise issue is really minimal. They're very, very quiet now. But the other issues remain. And one of them is the big issue with CPAP is that you have to be able to breathe through your nose. If you can't breathe through your nose, you're not going to be able to use CPAP effectively. So my picture here is a nasal mask. And with that nasal mask, the idea is that the air pressure pushes the soft palate down against the back of the tongue. And that creates a seal so that the patient just breathes in and out through their nose. If they open their mouth, the tongue will drop down, it'll break that seal, and air will just go in through their nose and out through their mouth. This has a extremely drying effect on the mouth, and it's very uncomfortable, and patients will stop using CPAP if that happens too much. There are CPAP masks that fit over the mouth also. And the ones that fit over the mouth, that's fine that they fit over the mouth, but you have to keep your mouth closed anyway, because if you try to open your mouth and breathe through your mouth with CPAP in place, one of two things happens. One is that you'll have what we call reverse apnea, where the pressure, air pressure and or the pressure of the bottom edge of the mask will push the jaw backwards, and that will further crowd the airway. So the full face mask can sometimes make sleep apnea worse. We run into that every once in a while. But the real big problem, the more common problem, is that when you're breathing through your mouth with this, with a full face mask that fits over your mouth, is that your mouth's going to get really dry, because the masks are, they have an intentional leak built into them, and about 20 to 30 liters of air blows through them every minute. And for comparison, like a tidal volume for a normal person is somewhere less than 5 liters a minute. Okay. I think we talked about that a little bit. So the importance of the nose. So for normal breathing, the nose is really important for three things. Humidifying air, so it humidifies the air that we breathe in, and heating the air, and filtration of small particles in the air before it gets to your lungs. And then for sleep doctors, the nose is really important for the use of CPAP. This is one of my sons, Ian, and Ian, this is Ian's nose. And so he's going to be a model today. So with the external nasal anatomy is important to understand when you're talking about this subject. The ala, ALA, is the Latin word for wing. And so this part of your nose here is called the wing of the nose, so ala nasi. There's a little fold of skin here, the alar nasal sulcus, and the nostril, the anterior nares, and then the philtrum, which is the space between the bottom of the nose and the top of the lip. You can see he's been breathing through his mouth a little bit. He actually has a little bit of allergic rhinitis and has been breathing through his mouth a little bit, and this was in the winter, so he's got some lip liquor dermatitis from having dry lips. This is one of my other sons, Leonardo, and Leo is demonstrating his external nasal valves. So you actually have two sets of nasal valves. You have the external ones, which are at the edge of your nose here, and you can see that Leo's external nasal valve is here. He's spreading it open just by contracting the muscles of his face. And then there's internal nasal valves, which you can't see, and the internal nasal valves are near that alar nasal sulcus, and there's another place where you can have extreme narrowing of the airway. The external nasal valve is actually the most narrowest part of your airway, generally speaking. So when we talk about nasal pathophysiology that's related to sleep apnea, there's really four mechanisms by which nasal problems and nasal congestion make sleep apnea worse or more difficult to treat. The first is this thing called the Starling resistor model. So this is a really common concept when we talk about the upper airway in sleep medicine. There's the resistor model has two rigid segments, an upper segment and a lower segment, and then a collapsible middle segment that's sort of in a closed box. So there's a certain amount of pressure in the upper and lower segments, and then a certain amount of pressure in the intraluminal space in the middle, in that collapsible segment, and there's extraluminal pressure too. So one of the ways that people can get sleep apnea is that if they have a really big neck, that weight tends to collapse the airway, and it does that by increasing the extraluminal pressure. So there is a certain amount of muscle tone that's present in the airway, and if you exceed the ability of that airway to stay open, you'll get collapse and you'll get hypopnea or apnea. So that pressure, and the pressure that's required to close it is called the critical closing pressure, or P-crit as it's called. And so making sure you don't exceed that is important in order to keep your airway open. So CPAP, as I mentioned earlier, improves this by increasing the intraluminal pressure, and that's the strategy that's been most successful in treating sleep apnea. But this collapse problem is an issue when you have more resistance in the upper segment. And I like to think of this like, I call this the clogged straw effect. So imagine that you're drinking a strawberry milkshake, and everything's going fine and you're enjoying it through your straw, and then a strawberry gets stuck in the end, or partially stuck in the end. What happens? Well, you keep sucking on it, but it's not, you're not getting any milkshakes. You keep sucking harder and harder, and that negative pressure collapses the straw. And that's what happens with this airway, and that's how nasal resistance worsens sleep apnea. So if you have really bad nasal resistance, then instead of dying, what you'll do is you will start breathing through your mouth, and that's what everybody does. But really, oral breathing is really our second choice. Oral breathing increases your total airway resistance about 2.5 times that of breathing through a normal nose. And that's due primarily to two things. One is a decrease in the diameter of the upper airway due to the retraction of the tongue. And so when you open your jaw drops down, but it's on a hinge, so it drops backwards too. And the tongue drops down and backwards also. And there is actually narrowing of the airway when you do that. If you get narrow enough an airway, in order to get the same volume of air through that narrow airway, you have to increase the flow of air. And when you increase the flow of air, you end up getting oscillations of that muscle, the muscle walls or the walls of the oropharynx and nasopharynx. And that's where we get snoring. And so you can see this picture of this man here with his mouth open sleeping, and you can just hear him snoring in your mind, I hope. That's what I see when I look at this. There are other things. So there are nasal receptors in your nose that improve ventilation and increase your tidal volume compared to oral breathing, or compared to, and we know this because there's been studies done back in the 80s now, where they saw increases in apnea events in normal subjects that had anesthetized noses compared to baseline. Another thing they found was this thing called, another study looked at this, and we have this thing called the negative pressure reflex. So the negative pressure reflex is when you breathe in through your nose, there are receptors in your nose that help, there's a reflex to increase the muscle tone in the genioglossus muscle, which is the main muscle that pushes your tongue forward, and also some other muscles in the upper airway. And so on our little diagram here, the genioglossus EMG is on the top here on the A side, and then we have the airway pressure here on the bottom. And you can see that when we have a pressure drop in that airway, then there's actually an increase in the genioglossus muscle EMG activity. So increased tone in the genioglossus muscle. If you anesthetize that same nose, you can see that that effect is really blunted. So this is a reflex that you have when you breathe through your nose, and it's not really present when you breathe through your mouth. And a fourth method, a fourth reason that it's important to breathe through your nose is nitric oxide. It's made in the nose and sinuses, and it is an aerotransmitter that acts between the nose and the sinuses and the lungs. It is a lung vasodilator. It helps improve VQ mismatch and improves overall blood oxygenation. It has a role in maintaining or improving muscle tone in the pharyngeal muscles, although that hasn't all been worked out exactly how it's doing that, but it seems to have a role there too. So these are our symptoms of nasal obstruction. I always ask the second question, is this an alternating or fixed nasal obstruction that you're experiencing? Because that helps guide my decision making when I see patients in the allergy clinic. If it's a fixed obstruction, that suggests a structural problem versus an alternating problem, which suggests that it's inflammatory or possibly venous pooling that's causing the issue. Difficulty breathing through one or both sides of the nose, nasal congestion, rhinorrhea. Supine nasal congestion is something we run into. That's due to a rostral shift of fluids when you're laying down for long periods of time, like when you're sleeping. And so there tends to be a little bit more nasal congestion when people are laying down. Recurrent sinus infection is another one. And then, of course, itchy and burning eyes with allergic conjunctivitis, which often goes hand in hand with allergic rhinitis. And then finally, just mouth breathing. If you can't breathe through your nose, you're going to breathe through your mouth. When we talk about sleep-related breathing disorders, these are some of the things that we see. So snoring is, of course, very common. I will tell you that only about 50% of patients that have sleep apnea have a history of snoring. Part of it is that they may not snore, but the other part is that these events are happening when the patient's asleep. So their ability to recall accurately during a medical history is always diminished a little bit. The best people are witnesses, so bed partners that can tell us what's going on. I'm always happy when a spouse comes along to a sleep appointment because it really helps us out a bit. If there's the parents, the bed partner may also notice cessation of breathing during sleep. So snoring, and it typically is accompanied by louder and louder snoring, followed by no breathing, and then the patient sort of stirring and awakening and then gasping for breath. That's a very typical story to hear. Excessive daytime sleepiness. So if you don't have good sleep quality or quantity, you are going to eventually get excessive daytime sleepiness. Falling asleep at work while you're doing things, watching TV, falling asleep in the car, all those things are things we ask about in the sleep clinic. Sleep apnea has been, especially moderate and severe sleep apnea, have been linked to hypertension and other cardiac disorders, especially atrial fibrillation. They're also linked to strokes too, for that matter. There appears, and it has to do partly with cardiopulmonary mechanics, but the other part is that the intermittent hypoxemia that happens with sleep apnea leads to endothelial dysfunction. So there's often a history of hypertension or other cardiac disorders. In fact, having hypertension is considered one of the risk factors for having sleep apnea. Patients with sleep apnea, because they don't get adequate or quality sleep, they often have problems with concentration, memory, sometimes emotional regulation. And then a few other symptoms that you might run into with sleep apnea: morning headache. So some patients will have elevated CO2 levels that rise and rise and rise as they go through the night, and they'll wake up with a headache that usually lasts maybe 30 minutes or so and then kind of goes away. That morning headache is a pretty classic sleep apnea symptom of that particular pattern. And it's a morning headache that happens almost every day. Night sweats are really common too. So when you feel like you're being choked to death, it elicits the sympathetic nervous system activation. So your heart rate will go up, you have this fight or flight reflex, and sweating goes along with that. So night sweats are another common symptom. And then finally, nocturia and uresis. We see patients that have sleep apnea and they will often wake up to go to the restroom multiple times a night. And it has to do with the fact that sleep apnea seems to interfere with the production of antidiuretic hormone. So I'm going to kind of turn to the physical exam. So the physical exam, when you look at everybody's going to look at your patients, just make sure you're taking a good look at their nose too. Patients that have really wide alar base width often have turbinate hypertrophy, and that can be a sign that that's a problem. Really narrow alar base width, so the nostrils are really narrow or slit-like, that may mean that they're having some nasal valve narrowing that's significant. And this also can be a sign that there's septal deviation. And then finally, a crooked nose, of course, worry about septal deviation, but also the nasal valve narrowing is a problem for them too. This lady on the right has nasal valve collapse. So the ala nasi are held open by they're held open by cartilage. When you breathe in through your nose, there is a drop in the pressure just inside your nose while you're doing that compared to the outside air. And so you have to have that cartilage, that stiff cartilage, to hold your nose open while you breathe in. If you don't have that good stiff cartilage because it's been destroyed by whatever means, you'll have this external nasal valve collapse. This is something that you need to send patients. When you see this, you need to send these patients to ENT. There are procedures that are done. They basically take cartilage from somewhere else in their body and they make what they call a batten, which is sort of oval-shaped piece of cartilage that they stick in there to stiffen the ala nasi. A maneuver that you can do, this is my son Peter, and he's demonstrating the Cottle maneuver. And the Cottle maneuver is just a way to test for this. So if you have a patient that says they can't breathe through their nose and they have slit-like nostrils, they can just do this thing where you kind of tug on the cheek a little bit and have the patient breathe in. And when they breathe in, it should be much easier for them to breathe through their nose when they do that. This is something that the ENT doctors do. You could absolutely do this in your clinic too. So this is my example of adenoidal facies. These little children obviously come from different parents, but they all sort of look alike, right? They have the same sort of shape of their face. So what's going on with their face? Well, a lot of them have allergic shiners, like this little girl here. Their nasolabial folds are either absent or diminished, so their face is kind of flat. There's not that fold there. They all have their mouth open because they're breathing through their mouth. The philtrum is a little bit long in all of these children, and the lip is elevated too, and you can see that with this little boy in particular. children, you can see this little protruding tongue thing that's happening with some of these kids too. So that's another thing that children with adenoidal facies do. So when you chronically breathe through your mouth, you actually change the activation of the muscles in your face, and it influences the way your face grows. So this is when children have adenoidal facies, they often have high arch palate. And it's not that the palate is high, it's that their caudal growth of the maxilla is pronounced. And so they have sort of a long face. So adults that have had untreated nasal obstruction and during their formative years will often have a really long, narrow face. And it's because of this issue. And we know that really actually from these monkey studies. So this is a paper that was published in 1981. A researcher took some baby rhesus monkeys and they put silicone nose plug, cone-shaped silicone nose plugs in their noses so they could breathe out through their nose, but they couldn't breathe in. So this is a normal rhesus monkey face and a normal rhesus monkey tongue here. And this is the result of what happened when you put these silicone plugs in. So you can see here in the A here, this is one of these monkeys that has that long, narrow face. As you compare that face to the one on the previous slide, you can see how this rhesus monkey's face is a little bit wider. They also develop a lot of dentition problems, so they get underbites, overbites, and cross bites where the teeth don't really line up very well. So people that, and monkeys, I guess too, that have chronic oral breathing often have dental problems. And my dentist friends tell me that they often have a lot of cavities too from having a dry mouth so often. The monkeys develop these different sort of strategies to humidify the air, because remember, your nose is supposed to be doing the humidification. Your mouth can do a little bit, but it doesn't keep up. And so these monkeys, this monkey here has this sort of V-shaped crease in their tongue from breathing through this sort of, they made this oral breathing channel with the tongue and the upper lip. This monkey here has a triple channel, so one channel here, here, and here. This monkey has two channels on either side of the tongue. But all these strategies are to, to humidify that air. And this is one of my favorite slides. I like to show this almost every talk I talk about nose problems. And really, it's for our allergy audience, it's kind of old news, but I like to talk about it anyway. This little girl has some clues to rhinitis that aren't necessarily on the nose. The Denny lines under her eyes, these allergic shiners, a little boy doing the allergic salute, and eventually developing an allergic crease when he does that enough. And then the conjunctivitis. So when I see conjunctivitis, I always think about the nose too. And then finally, just eczema, which is that very common first thing that you see in someone that's going to have an atopic problem. So how can an allergist improve sleep? One is you identify and treat the chronic nasal obstruction, and then if it's inflammatory, you manage those inflammatory causes of nasal obstruction. This is a table I got from an ENT text. So they predictably have divided everything up into structural problems, which they can do surgery on, and inflammatory and mucosal problems, which they really can't. I would say that allergists would like to divide everything into allergic rhinitis and then non-allergic rhinitis. These are some causes of nasal obstruction that we should think about. In sleep, when we talk about treating nasal obstruction and nasal congestion in sleep, really my go-to thing is intranasal steroids. It's effective and safe treatment for rhinitis, and as you all know, it's for allergic and non-allergic rhinitis. It will decrease all those symptoms, the nasal congestion and the rhinorrhea and postnasal drip that people can get with rhinitis. And the side effects are pretty well known, but controllable with dry nose, epistaxis, nasal ulcers, and possibly septal perforation if it's used too much. There's also an additional benefit that you may not know about, which is that it might decrease the apnea-hypopnea index and improve breathing during sleep. This is a study done in 2001. This is from a group of children where it was just a parallel group design. These children had obstructive sleep apnea that was pretty moderate, and the fluticasone group after treatment had improved from apnea-hypopnea index of 10 to about 5, so 40%, maybe 50% improvement. And the fluticasone group, while the placebo group really didn't change. This is another study in children from 2004. And in this study, we had this group of patients had a apnea-hypopnea index of around 5 starting out. And then 2 weeks after treatment had improved to about 3. So I bring this up because one of the things that we do when we treat sleep apnea in children, CPAP is kind of our last resort. Tonsillectomy and adenoidectomy is often the first thing we try to do because that often solves a problem. An adjunctive treatment for sleep apnea is the use of nasal steroids, and it's based largely on these papers that I'm talking about now. In this case, these children, and the goal for treating sleep apnea is to get that apnea-hypopnea index less than 5 events per hour, sort of the goal. That's our standard for adequate treatment. And you can see that in this group, we did get that improvement. For children that have relatively low apnea-hypopnea index, if they still have apnea and hypopnea and they have nasal congestion, it's really important to treat it because you can really improve their sleep. This is a study from 2004. It was 23 patients in a crossover design study using fluticasone for 4 weeks and then placebo for 4 weeks. They had 2 groups in this patient. They were all snorers, but there were the apneic snorers and the non-apneic snorers. Focusing on the apneic snorers, these patients in the fluticasone group, when they were on fluticasone, had an apnea-hypopnea index of 23, and then in the placebo group, an apnea-hypopnea index of 30 on average. So they did see some significant improvement again with fluticasone. So, and this is the line plot from that same study. Some patients had really dramatic improvement, like this patient had kind of moderate sleep apnea for an adult and went down to pretty much gone. So see a lot of improvement with nasal steroids. Oxymetazoline is another drug that we use sometimes. It is an adrenomimetic. The brand name is Afrin, if you don't know that, but that's a common one. But oxymetazoline is what we'll call it. It's a non-selective agonist for alpha-1 receptors, and it causes vasoconstriction in nasovascular beds. As you all know, the onset is very fast, within just a few minutes, and it lasts for a few hours. We always worry about rhinitis medicamentosa. And so how does that happen? So normally you have these circulating catecholamines that are in your body, in your blood, and they circulate and they activate these nasal alpha-1 receptors, and they cause vasoconstriction and keep you from having too much venous pooling. When you have chronic oxymetazoline use, those alpha-1 receptors get internalized, and there's sort of this decoupling from that process, and you end up with this sort of baseline nasal vasodilation. There also seems to be some histologic nasal mucosal changes with chronic use. And so patients will use it, and they have to keep using more and more of this oxymetazoline. When they stop, they have this really bad rebound nasal congestion with it. There has one study, this one in 2010, showed that you could actually reverse this with some intranasal fluticasone within about 3 days. And I'll show you that in just a minute. So when you're talking about oxymetazoline, 1 spray is equal to 100 micrograms. So one question I had was, well, how much can you get away with, right? If you wanted to use oxymetazoline chronically, how could you use it so that you could use it every single day or every other day, whatever it is? That study from 2010, they gave normal subjects 14 days of oxymetazoline, so 2 sprays in each nostril 3 times a day, and that caused rhinitis medicamentosa. But there was another study done where they used just 2 sprays 1 time a day and for 28 days, and they did not develop this problem. And then another study where they used for 28 2 sprays 3 times a day, and again, they didn't detect rhinitis medicamentosa in that study. So this is that second study I talked about, Baruti. So this study was really interesting, and it actually, for me, it actually changed how I felt about oxymetazoline. So they had this group, they had four arms in this study. They had a placebo arm, fluticasone furoate arm, oxymetazoline arm, and then fluticasone and oxymetazoline together, which are these black circles. And what we're looking at here is the nasal negative pressure inspiratory flow through the nose. And you can see that with use of fluticasone and oxymetazoline, and a little bit to a lesser extent the other things, we had improvement in inspiratory flow through the nose. And then when they stopped the medication, like it kind of just went back down to the baseline. But the important thing is that it didn't really get worse. Even with the oxymetazoline group, it didn't really get statistically, there wasn't a statistically significant worsening. So there is that. And then as far as treating it, fluticasone will rapidly resolve the rhinitis medicamentosa. This is from the first study I mentioned. And so they used 28 days of treatment with nothing else, just oxymetazoline 3 times a day. And with the treatment, what they saw is at the end of the treatment, they stopped it and they had a real decrease in their nasal inspiratory flow, they had an increase in the nasal airway resistance, and then the mucosal blood flow increased to the nose too. But then within 3 days, they had some improvement in both the nasal airway resistance and the nasal inspiratory flow to about the normal, basically back to baseline. So one question is like, well, could I just use oxymetazoline then all by itself to treat sleep apnea? So that's a good question. This has sort of been answered. There's another medication that we do not use in the United States called xylometazoline. It acts the same way as oxymetazoline. It's pretty much the same thing. And this was just a really small study. It was a crossover design that all these patients had severe sleep apnea, hypopnea index of 32. So more than 30 events an hour in an adult is considered severe. And what they found was there was a significant, there was a statistically significant decrease in the AHI for a few hours after use, but they didn't see any change in this Epworth sleepiness scale. So it's just a measure of how sleepy you are, no change in that, and then no change in sleep quality or how long it took to fall asleep, the sleep latency. Hold on, I'm getting my slide. There we go.
Dr. Robertson, we are at about 1:45, so if we can get to questions in a few minutes, that would be great.
Yeah, absolutely. Absolutely. And this is just another study looking at alpha agonists. This was oxymetazoline. They saw a decrease in the AHI from 45 to 33 events per hour. In this study, they actually did see some improved sleep efficiency and increased deep sleep, so N3 sleep it's called, and REM sleep, which is, those are both good things. Cromolyns can be used, as you're probably pretty familiar with those. I won't, in the interest of time, I won't belabor this. There's no information, there's no research on using them with CPAP, with Cromolyns with CPAP, so I don't have any information about that. Ipratropium nasal spray can also be used, and we do use that in the sleep medicine clinic. But it only treats rhinorrhea, so I only break this out if rhinorrhea seems to be the big issue, usually with vasomotor rhinitis or gustatory rhinitis. And then finally, Azelastine, which has an indication with vasomotor rhinitis and might decrease nasal congestion. It showed improved. There's one study I found about this that kind of looked at this question of nasal congestion, really didn't show improvement in nasal congestion, but did see improvement in rhinorrhea. And then montelukast, there's very little data on its use in sleep apnea. And as you know, it can cause some nightmare problems, which has been an issue in my practice. I've had to stop it a few times because of nightmares with this medication. It's on the FDA label that is a known side effect with it. Antihistamines, I don't really reach for in the sleep clinic, mostly because they don't really have a lot of effect on nasal congestion, which is our patient's big issue. And then as far as allergy shots, I mean, I wish I knew how they affected sleep apnea. There's, to my knowledge, no research on that question. So kind of to summarize, it's important to breathe through your nose. And if you have sleep apnea and you're using CPAP, it's really, really important to breathe through your nose. If a patient is having difficulty breathing through the nose and having nasal obstruction, then using nasal steroids would be my first line choice for treatment. And if they can do it, one thing I have done in the past is using oxymetazoline, 1 spray in each nostril, no more than one time every 24 hours. And if they do that, then if they have nasal congestion when they go to bed, that will quickly relieve it so they can fall asleep. But as long as we can, and then I'll have them always use nasal steroids while they're using the oxymetazoline. And that's been pretty effective in my sleep practice. I haven't really broke that out too much in my allergy practice, so but that remains an option for these patients too. And I think that's all I have. This is my bibliography, and I'll take any questions you have.
Thank you so much, Dr. Roberts. And I learned so much. So we do have questions for you today. The first question is, what are common signs and symptoms of sleep problems in children with asthma and or allergic rhinitis?
Okay, so pediatric patients with many different kinds of allergic problems have sleep problems too, including patients with asthma and allergic rhinitis, but also urticaria and atopic dermatitis. For many of these patients, this can include like daytime sleepiness, difficulty falling asleep and staying asleep at night, and having fragmented and poor quality sleep. For some patients, for some children, that poor quality sleep often results in hyperactivity and difficulties with attention during the day. So those things you can find. And then I also noticed during asthma exacerbations, patients can have overinflated lungs, which makes it more difficult to adequately breathe during sleep. And then albuterol and oral steroids like prednisone or prednisolone, they have side effects that can cause poor quality sleep too. So those are the things you should watch out for there.
Thank you. When should parents consider seeing an allergist for their child's sleep-related breathing disorder?
So if the asthma and allergic rhinitis are poorly controlled, they definitely need to see an allergist. As far as sleep symptoms, if they notice snoring or episodes where the child stops breathing or struggles to breathe during their sleep, they should get some help there too. And then finally, if they notice those daytime sleepiness of poor sleep, such as excessive sleepiness, but also behavioral problems that can mimic ADHD and inattention, those would be good reasons to see an allergist for that group of patients.
Thank you. Our next question is, what is the effect of food intolerances? And our question is thinking about corn and gluten and dairy on sleep. What's the effect of that on sleep?
I mean, if any kind of discomfort or pain will cause more fragmented sleep. So if those, like if the gluten intolerance is causing abdominal pain, you're going to have worse sleep. And that's something that we actually see a lot in the sleep clinic. Patients with pain don't sleep well. That discomfort. Specific things about those intolerances, other than that, there aren't too many. If they eat those foods at night, or eating really any food at night, that tends to worsen sleep too. It's actually better to go to sleep with a not very full belly. That's another thing, and that's more of just a physical thing. If you have a full belly, it kind of pushes up on the diaphragm and makes it a little more uncomfortable to breathe. And it also increases reflux problems, which, as I mentioned before, lead to lots of other issues.
Oh, that's very interesting. Our next question is, what is the role of an at-home versus observed sleep study and cost effectiveness? Which patient needs an at-home versus an observed sleep study?
So the home sleep tests have not been approved for children. So a good blanket statement is that children need an in-lab sleep study. The home sleep tests are much more cost effective. They're definitely cheaper than doing the in-lab study. They tend to be a little less accurate. So sometimes what a very typical pattern will be for like a hospital system or a clinic to try home sleep test first. And if there's really two reasons to test, right? You want to try to rule in or rule out. If you really don't think the patient has sleep apnea and that AHI score on the home sleep test is very low, you probably ruled it out because your pretest probability was kind of low. But if your pretest probability is high and you get a barely negative test, it's almost at that sort of line of 5 events an hour to call it sleep apnea, then we'll repeat the in-lab sleep study. We also use in-lab sleep studies to do what we call CPAP titration, where we adjust the pressure of CPAP and we find the right pressure for that patient. That has to be done in the lab and can't be done at home.
Okay. Our next question is from Julie, and she's asking, are there alternatives to CPAP for sleep apnea?
There absolutely are. So one of the most common ones is an oral appliance. It's basically, it looks like 2 mouth guards that hook or fasten together. And what it does is, and they're adjustable if they're made by a dentist. And these things are adjustable. And what it does is it pulls the jaw forward just a few millimeters, and pulling the jaw forward pulls the tongue forward, and it creates more space in the airway. So all of the treatments for sleep apnea are about making more space. And that's how that one works. That is really good for mild sleep apnea and maybe moderate sleep apnea too. For severe sleep apnea in adults, that's usually not effective, although I have had exception to that rule. There are surgical treatments for this. As I mentioned, tonsillectomy and adenoidectomy for children that's a first-line treatment, but can be considered in adults that have large tonsils. And finally, there's oral maxillofacial surgeons have a variety of surgeries they can do, and ENT surgeons have a variety of other procedures that they can do. The gold standard for treatment is CPAP, though. That seems to work the best of all of those. With the surgical procedures, my opinion is that the maxillary mandibular advancement done by oromaxillofacial surgeons can be the most effective thing, surgical intervention. But it's a pretty involved surgery. Basically, you move the jaw, the maxillary and mandibular parts of your face forward. Someone that has a really soft chin, that can be a really effective treatment for them, not to mention making them look more attractive, which the patients like.
Okay. Well, our next question is, can you explain the increased problematic behavior in ADHD autism when there is sleep disruption?
Yeah, so I didn't really cover it in this talk, but autism and sleep are, children with autism tend to have poor sleep. There have been some studies showing that melatonin helps those children quite a bit. But I think the question was more about, like, why do children that have poor sleep have ADHD-like symptoms? So insufficient sleep is what happens when you have sleep apnea. You get either not enough, so you have poor quantity of sleep, or your quality of the sleep that you do get is bad too. And so these patients basically don't get adequate sleep. When you have insufficient sleep, that leads to problems with memory and attention in particular, and they have cognition issues too. Patients that have, and then children, adults, if you don't get enough sleep, they tend to just be sleepy. But kids aren't quite like that. They can get kind of hyperactive, and that's something else that's been associated with sleep apnea in children.
Okay, we have next question comes from a patient. He's saying he has recently experienced a declining benefit of intranasal corticosteroids in rhinitis. Any thoughts? Should I try a different one? Thanks.
So there aren't any head-to-head trials of intranasal steroids. I do not doubt that there are some people that respond to certain ones better than others. So yes, I think that would be a great idea. There's plenty of them on the market. You can try it. You don't even have to go to the doctor for that. They're over the counter. You can just go pick another one and try that one out. That would be the next thing. And the other thing is, like, if nasal steroids aren't really working, like, going to see an allergist might actually be a really good idea. Because they would be able to do allergy testing. And if you do have allergic rhinitis, allergen immunotherapy, like allergy shots, can be very, very effective.
Okay, our next question is, what, if any, long-term effects do intranasal steroids cause? And is there a big difference of efficacy between the different nasal steroids?
So I'll answer the second part because that's the easy one. Not that we know of. I basically use and think of them as equivalent. The side effects that you can get, really the big one is if you use too much of it, it tends to cause like a dry nose sensation, which can be kind of painful for some patients. And then you can also get nosebleeds. So when you spray the intranasal steroid in your nose, it's important to not spray it on the septum or the wall in the middle of your nose. And the best way to do that is put it in your left nostril and point it at your left ear and spray, and then put it in your right nostril and point it at your right ear and spray. And that keeps it away. The other thing is, like, to get the nasal steroid just in your nose and not in the back of your mouth or the back of your throat. So a quick sniff is all you really need to do. And if it feels like it's going to drip out, just tilt your head back. Don't try to sniff it back in. Just tilt your head back for a few seconds and it'll run backwards.
Appreciate all this practical information. Our next question is, can chronic rhinitis cause you to awaken with wheezing?
Can chronic rhinitis cause you to awaken with wheezing? The rhinitis itself is probably not going to cause wheezing. Rhinitis can cause snoring for sure, and sort of uncomfortable sleep. If you had wheezing when you have rhinitis, I would worry more about asthma and think about that.
Okay, and our last question, we had so many great questions, but we're going to run out of time. Our last question is, what is the effect of obesity on sleep apnea?
That's an excellent question. So obesity, people that are obese have big necks, and that increases their risk of having sleep apnea. Patients that have sleep apnea, even if they lose about 10% of their body weight, can have significant improvements in sleep apnea just with weight loss. It is something that we recommend. Unfortunately, it's really, it's one of those easier said than done things. But yes, obesity is a major risk factor. And in fact, there are a few things, and I mentioned some of them today, but obviously not all of them. These risk factors for sleep apnea, obesity is one of them.
Okay, well, thank you so much, Dr. Robertson, for joining us today. And we just learned so much, and you had great information for us. At this time, I'd like to encourage our listeners to download your certificate of attendance from your control panel if you need to have that. If you have any difficulties, please email us using the link in your emails. Please join us next month for our March 2021 webinar when Dr. Todd Marr will present on Breathe Easier, Smoking Facts and Cessation Tips. The webinar will air on Thursday, March 25th at 4 p.m. Eastern. You can register for this webinar on our website at allergyasthmanetwork.org. Look for news in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our recorded webinars on this page on our website. Visit our website for quality guidelines-based resources on allergy and asthma. Also, access important medical information on allergy and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network, wishing you a healthy day as we work to breathe better together.